So, good morning from Budapest. This is day 3, the last day of the European Pain Federation Congress, the 13th Pain in Europe Congress, as it were. We are back in the FX studio, as you see, and we are live, as you would know. And in the studio with me today, I have Professor McCracken, now of Sweden, but originally from the US. Would you let us know a little bit about yourself, maybe your background professionally and where you've been, what you're doing, and you've got to mention ACT at some point. I think people combine your name with ACT.
Yeah. So I am a trained clinical psychologist and the type of clinical psychologist who's interested in physical health. And then during my training, chose a specialty focus on chronic pain management, and I've done it ever since. So that was beginning a little while ago. Did my training in the US, worked in the US. Sometime around 1995, I heard of an approach that no one had ever heard of before, which was called acceptance and commitment therapy. There wasn't even a book on this at the time. I got my hands on an early working manual, and having just taken my first job as an assistant professor at University of Chicago, I thought this stuff is brilliant. And that's where it all started. I combed through that stuff. I took out this preliminary manual. I got my hands on a PhD thesis. I took that apart. I took a measure out of the appendix, which was called the ACPT, which wasn't a name. It wasn't even an abbreviation. And I talked to the guy who did the thesis, and I said, "What is the name of this measure?" "I don't know, we never really named it." And I said, "Is it okay if I call it the Chronic Pain Acceptance Questionnaire?" And he said, "Yeah, okay." And basically that's when we started getting data on this. By 1998, we had an accepted paper in the journal Pain, and it's all...
And at this point, back in time, psychology was not really a welcome part of, so it was mentioned, it was there, so there's been people before you obviously working with psychology into the chronic pain, but I felt it was almost they had to excuse their presence, like we know there's an insult, we know there's an injury, but then there's also the psychological aspects. I
think we've been on this sort of uphill slope for decades. I mean, obviously there were approaches in the 60s and in the 70s, and then 1983 is I think a date many people will know because Dennis Turk and colleagues wrote a book on like kind of the CBT approach to chronic pain. Yeah, early 80s, and that really, I think that really kicked things off. But it's been a learning curve for the field, I think, ever since. I'd like to think psychology is more and more integrated, understood, and appreciated. But I think we gain a little ground every day, and we also change and evolve. I mean, this is not 1983 style anymore. We've come up with tons of brilliant new ideas.
So Michael Nicholas in London at St. Thomas's Hospital was what, late 90s approximately?
We'll have to call Mike and ask him.
Yeah.
I mean, but he was there obviously before he sort of showed up again at Sydney and started what he's doing there now. I don't remember the exact dates. That's probably the 90s, late 80s, 90s. He's going to hear this and he's going to think we got it all wrong. But yeah, I mean, that was an example of a service that really ran in a very CBT style and was a model, really, for the time. Yeah.
I think it actually became sort of the model, at least for multidisciplinary centers in Europe.
Yeah, I think you either went to Washington and you sort of learned from the operant people, the people developing behavioral approaches, or you might visit London and see Mike and pick up what they were doing. And certainly around the UK, that became the dominant model. And that was some decades ago. And that's not to say that it's gone or that it was wrong. It was a huge step forward, and we keep making steps forward. And I like to think that, I moved from the US and to the UK, and we started, I think, the next wave or generation of developments in Bath in 2000. And I think we became an option, another model. We became a place many people wanted to visit to see what we could call now this sort of contextual variant of CBT be like with these processes, something we'll talk about more, I know, including acceptance and values and diffusion and eventually the whole model of now what is widely understood and known as ACT.
Yeah, and along the way you've been doing your clinical work and tons of academic work as well, and you've been training people who are not necessarily psychologists by trade, to do ACT, and you've studied the effect of that, and I know there's a wide range of studies now done with people like physiotherapists being trained in ACT. You've been part of that, so that went on for quite a while, didn't it?
Yeah, I think this is important that we brought a treatment model, a set of concepts for thinking about organizing ourselves and studying pain treatment, and we brought it into our laboratory. Our laboratory was an interdisciplinary team with real live patients coming in every day, and that became the place where we studied what we were doing, designed what we were going to do, studied what we were doing, took guidance from the evidence, and I like to think that we refined it, but everyone was a part of it. All of the disciplines, physios, nurses, physicians, doctors, occupational therapists.
So if I was a patient and I came to St. Thomas's Hospital when you were leading the pain clinic there, what would I be told? What was the grand idea, as it were?
I think that what you would have been told when you first came through the door, or when you had your assessment and when you maybe reached the end of your assessment, would have been very similar to what Bill Fordyce and his colleagues probably told people, and that is, pain is complicated. We know you're suffering. We know you want to get your life back, and we can explore some ways to do that, and sort of there are things that you can do about it that could make a difference.
And so ACT is acceptance and commitment therapy.
Yes.
And I guess the grand misunderstanding is that acceptance means just to live with it, or it's give up. What would people be told in London at that time about acceptance?
I think the secret that I hope is widely understood by now is you wouldn't use the word acceptance on the first day, nor you might not use it at all, not in a formal way, not as an advertisement strategy for what you're doing, not as a way to help people understand it, because it's an immediate turnoff. So I think you wouldn't. It's a behind the scenes back room word. It's not at the front of the store room. So he wouldn't have said that. So obviously it's a bit of a dance. I mean, there's no lies or deception. You focus on, people are stuck, what they're doing. They know at some level it isn't working. And we can explore with them what will work better. So I think it's just nothing fancy, no confusing terms. And it shouldn't be frightening. It should be hopeful and empowering, best we can.
And so the outcome would be that the person with pain, chronic pain, is in a set of circumstances, and they need to get the best out of that. And the therapy essentially is helping them get the best out of it, with their own help as well as the help from others.
I like the way you said that. It's with a mix of things. Changing circumstances where they can be changed, and changing behavior where that's the best avenue. So it's that mixture, I think, of these two things. Yeah.
And I guess what is at least how I understand where you're going now is maybe not so much what happens out in the front room, but maybe what does happen in the back room. What are we thinking we are doing?
Probably both. It's probably both. So I mean, people may not realize this because I think we're still, I'm going to say hampered, but I don't mean that in a negative way. I think we're still kind of living in the shadow of a kind of way of doing things where you kind of need to know what you're doing from beginning to end. You need to like specify, map it out, and stick to the map. And what people may not realize, because we've been delivering treatment in this rather formalized, structured, set content way for so long, we think that's how you know what you're doing. We think the study showed that that's what worked, and therefore we must do that and not something else. To a certain extent, that is true, by the way. That is what the studies showed. All right. So we've, in that mold, we've taken ACT and we've delivered it that way. What we've missed is that this ACT thing is a prototype of a treatment approach that ideally ought to be very individually delivered.
Yeah.
What does this person need, almost like in this moment? And then let's keep doing that. Keep answering that question. Now that we made this headway, we've run into some difficulties. Now what do we need to do?
And just to maybe sort of maybe cut it out a bit more, a bit concrete. So what you're saying is that, for instance, when you do exercise for knee osteoarthritis, it's easy to think that if it helps, it's because you're stronger. But it turns out that may not explain why people get better on an individual level. But as a group, they might get stronger and they might be better and they might be more functional. So it's easy to be, convinced that strength is the measurement that is important.
Yeah, I find this really interesting because I think by now there are lots of studies that show that, when people with complex pain, complex disabling, distressing pain conditions demonstrate improvements. We've always, I think, in the back of our minds thought that that's physical change, that the psychology is creating physical change. But I think we keep looking at the data and we realize it ain't the getting stronger, the getting more flexible, or even more coordinated maybe, that's running the show. It's possibly more like psychological changes in behavior patterns that are driving this. And then would that mean, for instance, when you do these exercises, whatever they are, you feel more competent, empowered, or is that what you were saying? If you're in a social relationship, if you're having social interactions it's a treatment context with a social element, an accumulation of experience. There's learning going on. Every single moment there's learning going on. Yeah, it's kind of dressed up like physical rehab and physical change. But by now we know that a lot of psychological change, behavioral change is happening at the same time. And I think we've kind of maybe missed the signal that that at the end, it's not maybe the physical change that is the most fundamental point. But I changed myself. It's a mix of things that's going to be different for every person, but a lot of it is psychological and behavioral. And I like to say, and I know I say this, but I'm not sure everyone gets me or believes me, but we're all doing behavior change. If you get to the end of treatment, people aren't saying different things, doing different things, including are they going to keep coming to see you or not, or see someone else? If we don't get these changes, I don't care what you were doing, it didn't work. So by that measure, we all need to be in the behavior change business, and we need to optimize learning, initial behavior change, and integration of behavior change into real life.
So very simply said, if you have a person that comes into a pain clinic and you change the pain, but their behavior doesn't change, they still keep coming, they're still frustrated, they don't live their lives, then you could actually argue that the treatment, although the pain may be less, is not successful?
Well, it's definitely not completely successful, because if you got one change, and that is, I came in here with a pain of a 7 and now my pain's 3. Thank you for that. But you don't get any other change, it's a limited result, isn't it? You didn't really hit every outcome that ideally you would want to hit. And is that going to be sustainable? How much value is there in that? In a way, the answer to that question will depend on what did this person want when they first came here, and how well have we met their requirements.
And while individualized medicine sounds like something only physicians can do. This is essentially what, again, that's the topic of this conference, and that will be, I guess, what you're talking about in your plenary session later today as well.
That's right. So I try not to say individualized medicine, but I think we're all talking about the same concept. I think it's individualized healthcare or individualized treatment I'm comfortable with, because we're not all sort of doing medicine per se, but I hope, doing individualized health enhancement, improvement in functioning, or treatment.
So if you don't mind, I don't know really about acceptance and commitment therapy. I know of it, but I've never had any training. I don't have any formal sort of learning of it. But my understanding is that the backroom chat, as it were, why does it work, is linked to a concept called cognitive flexibility.
Psychological flexibility, but the terms are used interchangeably,
And would it be fair to say that if someone is flexible, so psychologically flexible, they are able to go with the flow and being helped more, as opposed to if they're more rigid?
I'd say there is a sense in which, when people engage in psychologically flexible behavior patterns, they're more able to capitalize on opportunity. They're more likely to make change when needed. They're less likely to get stuck in patterns that don't work very well, sort of by definition. I mean, this is what psychological flexibility is.
That's the issue, isn't it? We can't really measure it. So you can give a questionnaire, but by the end of the day, it's a construct that only exists within the minds of those who use that theory.
The model itself, with its 6 parts, which it has, it's a tool for clinicians. It can be converted into measures, so we can measure it. We can take self-reports. I think we can certainly define on a piece of paper what are psychologically flexible behavior patterns and which ones are psychologically inflexible. And then, strictly speaking, we can ask people, how much do you engage in these different behavior patterns, the inflexible ones and the flexible ones. So I don't think anyone will say it's perfect, the extent to which we can measure these. So there's always going to be, when we're relying on human reporting, there's going to be varying levels of skill and precision in that reporting. But I wouldn't go so far as to say we're unable. I think we can measure them to the extent that we can.
And I've had the great pleasure of listening to you giving plenaries a few times now, and one of the things that you show us is that when you use, broadly speaking, these cognitive theories and therapies on people with pain, they are helpful. And a range of other things as well, like depression and anxiety. They are helpful. Just generally speaking, almost like you would say about, for instance, exercise is generally helpful.
Yes.
But when we then look at the science, what we see is that the mean changes, but within that group, there's individual changes. And it always, I guess this is what you are looking into now, isn't it? Is, can we design things differently to understand what the individual needs and what ticks for them, as it were?
I, as you have mentioned, I have this plenary later today. I do hope I remember to say what I think is the most important message, which is there's a feeling of some discouragement that psychological treatments have spent these decades working on themselves and trying to get better, and we don't seem to be reflecting that in our average effect sizes. So it's very easy to say the effect size of psychological treatments, when studied carefully, is small. So that feels discouraging. But what I would like to say is, not for the people who receive the treatment, they are not for all of them. I think we have to essentially stop thinking that the only way to think about the effectiveness of treatments is in terms of that summary effect size. Behind that summary effect size will be people who do miraculous things. People have large effect sizes, medium effect sizes, small ones, none, and some people who get worse. And I think we're hiding that. We're burying that. we're saying that's all just unreliability or error or imprecision. Our measures aren't that great. And so small is what you get. That's what we tell people. I think that's misleading. There are people, so our measures are not perfect. So there will always be.
Can I just so when you say misleading,
yeah.
It's what the statistics show.
Yes.
So whilst it covers, it's a mean for group.
Yeah.
And that's statistically sound, so it's not the method you're out for, but it doesn't show the real effect that some people have. Is that what you're saying?
Correct. It is not wrong, okay? It's not wrong for what it is. A mean effect size is a mean effect size. But what we have to make sure that we carry with us is that is not everyone's effect size, no matter what you think. That would be a mistake. We have to be able to hold both of these points of view at the same time. For some people, our measures will say that they did great when they didn't, okay? So that's going to be in there. But there are people who go home and their effect size is bigger than small. I don't care what you say. And we are not capturing that. We need to be able to capture that and study it and understand those differences. So that's, in a nutshell, that's what I hope I will somehow say later today.
You heard it here first. Well, no, but so I think this really, really mimics what we see in the clinic.
Yeah.
So everyone who's been a clinician and worked with patients and have, done the deed and been there and seen a lot of patients know that not every treatment is successful, but you do see these changes. And then people come along like from their ivory towers saying, no, it doesn't work. You can't do that technique anymore. Yeah. It's outdated. Yeah. The evidence doesn't support it, whatever. Yeah. But you still see it works in the clinic. So I guess the question here is, could we do different? Could we, the academics, do different to show or to measure what actually clinicians experience? Yeah,
I think we can. But let me just say again what you just said. Okay. So I don't mean we should exaggerate how well we think we're doing, okay? Because we as clinicians, we have a very positive view of how well we do. And I think we're often not quite correct in that. But okay, so set that aside for a second. But there's no doubt that we will see people pre-treatment, post-treatment, they did great. We see them at follow-up, they're still doing great. We measure everything we want, they're doing great. And we see them again, and we see them again. This is believable. This is quite a serious signal that there's real substantial benefit here that's bigger than small. That is not everyone. That is not everyone by a long shot. So can clinicians move in this direction? Yes, I think we're in a better position than ever to do this because everyone here in this meeting and most people in the world, I'd be tempted to say, have a device in their pocket which gives the capability of tracking how well they're doing on a daily basis or maybe a few times a day. And if they put some data in there, it can go over to where their clinician is at, and we have statistical approaches that can analyze those data and can give the clinician guidance. What should I do with what's happening right now with this person? We need the science to feed the principles and understanding that needs to fit into that technology and make it work properly. But it's a bona fide opportunity that we should seize on.
Because I guess in the clinic, well, at least speaking from a physiotherapist perspective, where there's a lot of, I call them weekend courses, so there's lots of postgraduate training courses going on, and what we tend to do is focus on a specific theory that is then applied. So that could be ACT, or it could be a specific type of training, or it could be electromodalities, whatever. Yeah. And then we see these benefits, and they might stay, and they might be there over time, and we blame it on the intervention. Yeah. And I guess what you're saying is that applying what we know from science to do that and to measure those things, but not only measure whether or not it correlates with use of a specific technique, but actually look at what everyone is doing in their daily life.
Yes.
But it sounds very difficult.
It does sound. It sounds complex, and that may be daunting. In a way, it is complex. But I would say, what do you want? Do you want to do something simple that doesn't work? Or do you want to basically, wrestle with this issue, learn to do it in a better way, embrace some complexity. I mean, obviously we need better tools to regulate our own behavior as treatment providers. That'll help to deal with some of the complexity. But I think we might dream that there's going to be something that's really easy to learn, easy to train, and it's going to be super effective. I don't know what that's going to look like. I don't see that within reach. I think personally that we need to lean in the other direction. We need to embrace the complexity, find the patterns in it, and make change happen in a very individualized way. It's complex.
So just let me try and summarize if I get this right. So we know that some people benefit from treatment and some don't, but if we look at a group, we get a moderate or mild or small effect size. So if we look at individuals, but we only look at what we used to look at, which is did they get ACT or did they get CBT or did they do exercises?
Yes.
We are not really seeing the whole picture because there's so much more going on.
Yeah.
And this comes into what you call processes, and I would be tempted to call mechanisms. So let's imagine you give them a treatment, but if you open up for that box, there's a relationship, there's trust, there's how they slept, there's how they spoke with their spouse in the morning. Yeah. And that's essentially what you are suggesting we should look at, right? So look at all these factors, as many as possible, I assume. Yeah. And then see if on an individual that any of these seem to correlate, and when we have enough of these individual measurements over time, we could then start to look at it from a meta perspective and say it seems like, I don't know, whenever people have less than 4 hours of sleep, we see these deep dives in mood or whatever. Is that sort of?
It is kind of like
very simple. But
I mean, it is kind of like that. It's hard to summarize it in a couple quick sentences. But what you're saying here is important to mention, which is, I think in the past we've thought that we could do this in a certain way, where you take behavior therapy and compare it to cognitive behavioral therapy, and the superior one in the trial would be the one that we should do. And then later there's another kind of therapy, we'll compare that to the best current one, and then we just keep moving ahead like that. But we must be able to recognize right now that this isn't moving us ahead in terms of more benefit for more people for a longer period in time. So I'd say what we're saying fundamentally is sort of, okay, RCTs and systematic reviews are fine. They tell us something, but they don't tell us everything. We need to sort of go back to individual people, and we need to meet them with what they need, study that process of meeting them with what they need, watching that change happen for each person, optimizing that with the use of intensive longitudinal data. And when we've created their optimal individualized treatment experience, hitting all the processes of change that they need. Once we change something, the next barrier they're going to hit is going to be something else. We don't know what it's going to be yet, so we can't preordain that. Let's just keep hitting what they need. So that's in kind of without using too many fancy words, I think that's what we want to go for. And eventually, the assumption is, may not happen. We study these people, we see how it goes, we begin to see that some people are like other people, that there's regularity. We can cluster some of these folks. I don't know what they're going to look like, but this will be a very sort of inductive, data-oriented approach to this kind of, eventually there'll be subtypes. Eventually we'll have better clues that give better guidance, but only from the ground up, from one case at a time, which in cases come together. Probably not the fibromyalgia different from the low back pain, or the old and the young, or the man and the woman. Probably not. It'll probably be something different. I don't know what it'll be.
No. Yeah. And I guess if you were a clinician and you think, what does that mean to me? Would it be fair to say that instead of learning a technique and applying that, as it were, described theoretically for everyone, and assuming that you will have a set amount of effect during that, then you would be continuously monitoring the outcome of what you've done.
Yes.
So you have a range of tools and you apply them, and then you monitor individualized outcomes. Yeah. How well did it go? Did you meet new barriers? Yeah. Did you get worse? And then you adapt, maybe use the same tool, new tools, and then you continuously make sure that they have, hopefully a positive process.
You need 4 things. you need evidence-based processes of change. Whatever your discipline is, there's going to be mechanisms or processes of change. The things that you directly target, when you move them, you move outcome. It's shown in evidence.
That could be psychological flexibility.
It could be
one.
components of psychological flexibility, could be other things, emotional regulation, motivation, other behavior change processes. You're going to need methods that you know move those processes of change. You're going to need intensive data that can feed your choice of method.
So the methods here would be communication in a specific way may actually support or help someone be more psychologically flexible.
Yeah. I mean, there needs to be some kind of input into the system to provide that guidance, because we have the tools, we have the processes and methods, but we need to know when do these need to come on board. And I would say you need to have sort of a progressive theory or a set of philosophical assumptions behind that to keep progressing this field and to build on this.
Yeah.
Whatever progress you make, we're going to need to keep doing it. And I think you need a theory instead of assumptions that will feed that progressive.
Yeah, so if this works, the next step could be like this.
How can we keep refining it? What are the assumptions that we take to this work that organize how we do our studies? Even this notion of be more ideographic is kind of an assumption that I think we need to take into this. I don't know if that's 4 or 5 things.
So you need the manipulable thing, the process.
Mechanisms or processes of change need to be manipulable.
Yeah, and
Absolutely.
then you need a theory. And the fourth one?
So we need intensive longitudinal data. We need methods. We need processes, and we need theory.
Yeah, and how do you see this happening? Where I know we're not there yet, but imagine in 10 years' time you're looking back and say, I'm so glad we did this because that really helped me test these hypotheses.
Yeah. Well, we're going to need knowledge. We're going to need data to analyze so that we can develop this base of knowledge about. We have some pretty good contender processes, but they've probably not been identified from the best quality research methods that we need, because we're not yet doing studies of individual people very well, not enough. So our assumptions about what the processes are come from research approaches that aren't quite able to identify them as best as we could.
So what you're saying is that the first bit is done at a desk. Is that what you're saying?
Well, we need to plan studies and conduct them. Yeah.
And how would we? So again, looking back 10 years from now, what was the best thing you did with all the success you have in 10 years?
I think it's time to launch the studies that will give us the data and build the knowledge base. Will give us this set of processes of change. The physios will need theirs. The psychologists will need their. Everyone has their method sets that they use, and that they're going to have connected to those method sets are going to be these processes that have been demonstrated. I think we need to build that base of understanding.
I guess my assumption was that you would say we need something in those phones we have in our pockets that.
I think we already have it.
Information.
We already have the technology, and in fact, it's been assembled, it's been engineered, it exists. It's not widely available, but we have apps already that they include a pool of items. The sort of best we could come up with right now, the variables you want to track in longitudinal data. We have statistical procedures built into these apps. In terms of data collection and feedback to the clinician, the technology is already there. It's not fully vetted and tested. It's really quite, it's early days, but it is there. The pieces are there, and we can connect a platform to this other platform where the treatment elements live. And we can use the feedback from the data and the analytics to select the methods. And I, as a therapist, can actually do this from my desk. It's possible. So all the technology is there, but it's time to study it and refine it.
I can't wait.
Yeah.
Can you give us some information now how to move on? How you're moving on this?
Keep your eyes open. Look in the journals, the main journals in our field, Pain and European Journal of Pain, Journal of Pain, Clinical Journal. Look out for it. I know there are groups who are doing studies of process-based, individualized approaches. They'll be a bit rudimentary at first. Some of them, our concepts and our understanding is like really, I think, it's improving day to day, and the technology solutions as well. So yeah, keep your eyes open. Look for the key words: personalized, individualized, idiographic, idionomic, or process-based. And yeah, keep putting it in Google Scholar if you want, and wait till it shows up. And then yeah, I'd say let's all join up.
I guess the first thing you should do is come up with something that is much more descriptive than those words. They're just
no.
Rubbish.
I mean, we have some data. We'll come up with something. Hopefully this autumn we'll submit something. We have some, I think, pretty cool data that I think will, convincingly argue that the kind of get the data at 1 point in time, or 2 points in time, or 3 points in time with hundreds of people, that misses something. If you track the day-to-day experience of enough people, you see really interesting patterns of relations between mechanisms and outcome in a way that's very variable and heterogeneous and very individual. So I think we're going to be able to make that case, and I hope that'll be eye-opening for people, and they'll really kind of jump on board with this. And in 2 years, I think in Lyon, you will see more data on this. I think I can promise that. Yes, I can.
Well, again, you heard it here first. So I guess this is a nice place to end it, a cliffhanger. And when you say Lyon, that's because the next conference is going to be in Lyon.
That's right.
In 2 years' time. I want to thank you for your time and for your insights. As always, it's been an inspiration. Thank you for coming.